I believe it's good morning to you, Alison.
Good morning, Henry. How are you?
I'm well. It's great to see you. We had so much fun when you joined us for the ANZUP meeting back in July. And thank you for being such a great sport. We had some, as you know, there's been some general austerity measures in place for ANZUP meetings, and Alison was kind enough to provide the entertainment because we couldn't afford to pay for it.
I think you better qualify that the entertainment was singing, though.
Well, we got your, yes, your singing was wonderful, actually. It was you really impressed people that there's a lot more to you than being an oncologist, an amazing oncologist you are. Now, Alison is somebody who really needs no introduction at all. Everybody has heard about the Pout study, but there's nothing like hearing about the story of Pout from the horse's mouth. So, Alison, I think we might allow you to commence your presentation, and let's hope it all works.
Thanks very much, and it's very exciting for me to be able to think that you are 10.5 hours ahead, and I can do this from my desk where it's actually about 5 degrees outside. So just remember this when you're going out later on and enjoying yourselves. So I'm delighted to be able to talk to you today about how we, not just about what Pout was about, but how we actually put together the networks to be able to look at this very rare incidence tumour. So these are my disclosures. So before Pout, the evidence for adjuvant chemotherapy in upper tract urothelial cancer was about summarised by this particular slide. It really was a dead end with tumbleweed rolling across the fields. And this is because this is a rare incidence tumour. There are about 1,400 new diagnoses every year within the UK. And at the time of diagnosis, stage for stage, this is a more lethal disease than bladder cancer, with which it shares many similarities. At about 60% of tumours are locally advanced at the time of diagnosis. And of course, we know that the standard treatment is an en bloc nephroureterectomy. And after that, we don't have any data. So the standard practice in many countries has been for surveillance with chemotherapy given adjuvantly on a case-by-case basis. The data that we did have was really poor. It was all retrospective in case series, and this is typified by this one study that I referenced, which was a retrospective study of 43 patients from over a decade ago, looking at patients with either node positive or locally advanced disease. And in this small sample of 43 patients, 32 of them received chemotherapy and 11 had surveillance. And you can see from the slide that there was a tantalizing hint of a treatment effect coming from the chemotherapy in terms of both disease-free survival and in terms of overall survival. And then more recently, we had 2 large retrospective studies, bearing in mind that most of these are from the upper tract urothelial collaboration that have shown mixed results over the years in terms of whether adjuvant chemotherapy works or not. And we had this bold statement from the Yao group in 2017, which said that adjuvant chemotherapy doesn't improve survival. And this was the key thing with this is if you look at the numbers, there were around 1,500 patients, but only 300 of those received adjuvant chemotherapy. But 2 months later, there was another publication that said exactly the opposite. And this was led by, amongst other authors, Joachim Belmont and Steve Chang. And this said that in patients who had locally advanced or positive nodes after nephroureterectomy, then actually chemotherapy given adjuvantly was a good thing to do. And that there was a benefit across all of the subgroups that they studied in terms of fitness, surgical margins, age, and stage. So we really had mixed data. And this was until Pout came along. Those of you waiting for the manuscript, I'll give you an update. The New England Journal of Medicine have just turned us down because it's not breast cancer, basically, and because it's not funded by a commercial partner. So we're just applying to the Lancet at the moment. So hopefully it will be out very soon. But Pout was a phase 3 randomized trial of, as you know, perioperative chemotherapy versus surveillance in completely resected UTUC. And the trial schema was very straightforward. Patients had to have an en bloc nephroureterectomy and then eligible pathology, which was T2 to T4 disease. And they were allowed to have node positivity as long as those nodes had been removed macroscopically at the time of surgery, and then the patient had undergone a negative follow-up CT scan. Now, we didn't mandate a lymph node dissection because at the time Pout was submitted for funding, which was back in 2010. Lymph node dissection for UTUC was did not have level 1 evidence, and indeed it still doesn't have level 1 evidence. The patients obviously had to fulfill the usual criteria of fitness for chemotherapy, and then were stratified, so randomized on a 1-to-1 basis to either 4 cycles of adjuvant chemotherapy, platinum-based autosurveillance. And you can see that the follow-up schedule was very pragmatic with the standard imaging and cystoscopic follow-up, with the exception that we did an extra CT scan in the surveillance arm at 3 months, and that was put in at the request of the urologist that we discussed the trial with. Now, the type of chemotherapy in the study is very important in that all patients received gemcitabine at the standard dose of 1,000 milligrams per meter squared on day 1 and day 8. But the choice of the second drug, whether cisplatin or carboplatin, was mandated only on GFR. So if a patient had a GFR of greater than 50 mils per minute, they received cisplatin at a standard dose of 70 milligrams per meter squared on day 1. But if their GFR was between 30 to 49, they were not eligible to receive cisplatin and received carboplatin, pre-specified by centre at either AUC 4.5 or 5 on day 1. So if a patient was not quite fit for cisplatin because of other problems, but their GFR was good enough, that patient was not eligible to go into the Pout trial. The only reason in this protocol to get carboplatin was based on GFR alone. I'm assuming everyone can hear me all right. Nobody said anything there's a problem with the technical stuff. So the statistical design for Pout was that we assumed that the control rate, so disease-free survival at 3 years, which was identified as a key point of interest, was assumed to be 40%. And the trial was powered to detect a 15% improvement in DFS at 3 years, which gave us a sample size planned to be 338 patients. And obviously we had safety and efficacy with independent data monitoring committees with predefined stopping rules. So this was an ambitious trial of 15% improvement in DFS, which is larger than what they were looking at, I think, in the EORTC 30994 study. And the endpoints of the study were the 3-year disease-free survival, and then obviously toxicity and metastasis-free endpoints with compliance with treatment. Could we recruit to this trial in a low incidence population, overall survival and quality of life? So Pout opened to recruitment in May 2012 and stopped prematurely in November 2017 as the independent data monitoring committee deemed that we'd met the early stopping rules in favour of the intervention arm. And at that point, 261 patients had been recruited from 57 centres across the UK, had recruited at least 1 patient, but 75 were open. This is the money slide, which shows that we'd met the primary endpoint, not at 3 years, but at 2 years. Not with a 15% improvement in DFS, but with a 17% improvement in DFS. So you can see that at 2 years, 71% of patients were disease-free in those who'd had chemotherapy, and 54% in those who had had surveillance. And if we look at the forest plot here, what you'll see is that all of the subgroups, this was in favour of the treatment intervention. Now, some of the confidence intervals are wider because of the lower numbers in the subgroups. So we did a test for interaction, and that was negative, which tells you that there is no evidence of heterogeneity for treatment effect in any of the subgroups. So chemotherapy was of benefit irrespective of margin status, nodal status, or type of chemotherapy, because there has been some misunderstanding of this particular slide. So carboplatin worked as well as cisplatin. In terms of the secondary endpoint, metastasis-free survival was also positive in terms of a 16% difference between the arms. And although we can't really formally report on overall survival at the moment because we haven't had enough events as yet, you can see that there's a tantalising hint of a treatment benefit as the curves start to separate quite early. So obviously this was fantastic. And I then had time to go off and do lots of other things because I had nothing else to do, clearly in a full-time NHS job. So I did Jesus Christ Superstar earlier on this year. I did Carousel last year. These are all musicals for those of you that aren't particularly musical theatre oriented. I was the lead in 9 to 5, the musical. I was Sister Berta in The Sound of Music earlier this year, and had time to dress up as Snow White in another musical. And this is because running a trial in a rare incidence tumour is really easy to get a positive trial result. It's all like unicorns and rainbows. Actually, most of the time since the trial was funded, I felt pretty much like this. And I'll show you the reasons why shortly. So Pout should have failed. This is a low incidence tumour. So as I said at the start, there are only 1,300 new cases every year in the UK. There have been no trials in this area before, apart from the ODMIT-C study, which is of a single-shot nephroureterectomy, single-shot mitomycin post-nephroureterectomy, which was also a UK study. This is also not sexy drugs. It was old chemotherapy drugs, so it's not a new targeted treatment. And we obviously had a niche market with gatekeepers of the urologists. To add to the mix, the chief investigator on the study was a full-time clinical oncologist working in the NHS in a non-academic centre. So what do you start? How do you start with this sort of situation? Well, the first thing you need to do is to get your sites on board. So there was a need for this study, and the need came from the gatekeepers, which were the urologists. So we had an established network within the UK of engaged urologists on fairly straightforward studies, from studies in non-muscle invasive bladder cancer, such as the BOXIT trial, which was using celecoxib in patients with non-muscle invasive disease. We also managed to get a list of the key players who undertook nephroureterectomies from the British Association of Urological Surgeons database, and were able to contact all of those urologists. We needed to get the design right. So where you've got designs where you've got very different randomizations, you must be certain design is correct. So we asked the clinicians what they would do. So in terms of surgeons, we did an audit across all of the UK sites about their surgical technique, how they managed the lower end of the ureter, whether they did a pluck technique, whether they dissected it out fully, how they managed the nodes, whether they did a lymph node dissection or just macroscopic removal of what was there. We audited all the oncologists. We contacted the bladder cancer lead if they were known, the research need, the research delivery manager in the networks, anybody that we could in terms of the use of chemotherapy versus surveillance. Were they happy with randomizing to this sort of study? And also the thorny question, which has come up many times since I first presented the Pout data, in terms of which was better, an adjuvant versus a neoadjuvant study, with obviously the concerns about renal function. We also asked the patients, because these are the end users. If they don't want to go into a study, your study is doomed to fail. So we did this by convening 2 focus groups using the Macmillan and the Cancer Voices website, and we asked them 3 key questions. What about adjuvant treatment? What about neoadjuvant? And explain the terms. Would you want chemotherapy? Would you accept surveillance? So it was clear from the patient's viewpoint and clinicians that adjuvant was a clear favourite. Everybody was nervous about giving chemotherapy to patients where you didn't have a clear diagnosis of muscle invasive transitional cell carcinoma. It was also clear that no nodal dissection was the usual treatment. And we had the expectation that patients would want chemotherapy and that surveillance would be harder to sell. So this gave us the impetus to set up a qualitative sub-study to look at barriers to recruitment and to optimize recruitment. So you also need to invite the best trial management group, and we did this by inviting surgical subgroup members of Bowes Oncology, who weren't just ones who were in academic centres, but they were known to urologists across the UK. We had a specialist nurse, and we also had 2 patient representatives, one from our focus group and one who was Andrew Winterbottom, the very much missed CEO of Fight Bladder Cancer. You have to seize your opportunities where you can and maintain momentum. So well before the trial was ever funded, every time there was a urology meeting in the UK, I managed to hijack 5 minutes of the urologist's time on a platform as an uninvited guest. So you phone a friend, you ask if you can go on and talk about the study. We also went into the Bowes Oncology meeting in October 2010 with expression of interest forms and hijacked everybody that was leaving the room and got them to sign a form. And that was essential for funding. So when we looked at Pout's initial recruitment, you can see it was quite slow in the first year or so. And what did we need to do after that? So we phoned a friend, we rang the people around the EAU, and I went and talked to the European Urology Group when I was presenting a design of Pout poster. They voted in favour 60 to 40 of supporting a neoadjuvant study. Bearing in mind that was 2011, they still haven't got, I've only just got that study open, and we've closed Pout 2 years ago. In Canada, they were giving more adjuvant treatment than surveillance. And so I turned at that point to the ANZUC group to ask for help. So this was me going cap in hand saying, please, would you help me with this study? What actually happened was this. So you can see that the ANZUC group were very laid back about it. They were happy that I called them love, but they were not particularly keen on engaging with the study at that particular point in time. So we had to maximise the recruitment. We did this qualitative study where we audio taped the interviews with trial management group members and real life patients entered into the study. And then we gave top tip sheets both to urologists and oncologists based on anonymised feedback from that. And the key messages to avoid was certainly in that first surgical consultation, giving the message, I've done a nice operation and it's all gone. Because this was very much a drop mic moment. It closed the door to patients then going into a study of further treatment because they were told the cancer was all gone. We also gave separate information sheets to the oncologists, which was, you know, we use adjuvant chemotherapy in other settings. We don't know the answer in upper tract disease, but, you know, it's a good idea to think about it. And also being honest with patients about relapse rate. We also gave a 2-stage consent form, one to every patient undergoing a nephroureterectomy, and then one to bring back to their post-histology clinic. And we presented this at meetings throughout the country, whether it was urologists, oncologists, or nurses. We looked at the screening log. So our expectation was that patients wouldn't want chemotherapy, and would want chemotherapy. And actually what we found was the reverse. But we found that in the screening logs, the suggestion that they didn't want chemotherapy was just accepted at face value, and there was no attempt to challenge expectations. Patients were put down as unfit because of age, but if they were biologically fit and had a locally advanced tumour, they needed to be told the relapse rate within the next few years. And also they were referred outside of the window for treatment, i.e. they were brought back too late for their pathology at week 6. So what do we need to do? Well, regular emails across the country by me to the urologists to get them to recruit to the study. Teleconferences monthly every site, which I chaired or a TMG member shared. We shared best practice on the top tips, how to approach patients, how to identify them early, how to get them back to the clinic early. And within each of the networks, we named a Pout champion who would be the one at the multidisciplinary meetings to highlight that that patient preoperatively might be suitable for Pout. Where the trial wasn't open, I contacted the chief investigators. We kept pushing. I did personalised emails. I rang them. I didn't just leave it to the trials unit to do it. And we held road shows in the regions where there were few sites or low recruitments. So this really pushed the recruitment up. As you can see here from this slide, the graph started to go upwards. The personal touch really made the difference, and you have to believe in a study. So I was actually the lead recruiter for the site, so I recruited 19 patients for my network of 1.6 million. But it was a huge personal investment when I do a full-time NHS job. But doing those personalised emails, so dear John or dear Henry, how can I help you deliver this study? So the emphasis that we could work together to deliver this, not that it was just my trial, but it was the UK's trial. It was the UK uro-oncology community coming together to deliver it. And this meant when there was a competitor trial or looking at an IO monotherapy coming through, that the clinicians across the UK continued to support Pout. So that's why we did it, and that's why we recruited early to the study. So I can't be more thankful to everybody that recruited to this study across the UK, and in particular to my trial management group and the team at the ICR, and also to all of the participants in Pout. all 261 of them, and to CR UK for funding the study. Now, I am not going to float off like Mary Poppins into the distance because everything is wonderful. I am working on this, which is the successor study with chemotherapy as the standard arm with an IO added into that. And we have a member from ANZUP who's working with us on this with Lawrence Kriegler. So ANZUP, we really need you to support Pout 2 when it's ready to go. And I'm grateful to be able to share all of the data with you today. Thank you very much.
That was an absolutely wonderful presentation, Alison.
Thank you.
And you can see how, I think everybody in this audience can see just why Alison would go down as probably one of our most loved guests to ever come to our meeting.
Oh, bless you. That's really nice. I'd love to work with you again.
Yes. And also thank you very much for being a part of this little experiment. It went largely without any hitches. There were a couple of times when you sounded like you might have had a few drinks, but
a bit early even for me.
Yeah, I know it's a bit earlier, but it is England. And
well, I've got to find some way to get me through my clinic.
That's right. Exactly. Well, I know that you've got a very tight schedule, and we really appreciate you joining us. And thank you so much again. I think the audience has really absolutely loved your presentation.
That's great.
All right. We look forward to seeing you again soon. I've got to give you a call as well.
All right. Take care. Bye-bye,
Okay,
everybody.
bye-bye.
Thank you.
All right. I think we might break for the main course, and we'll see you shortly.
Yeah, usually we disable all of them.
I had to keep doing it. I know I thought it was going to go.